of the Urology Society when I was in the office bearers of the West Zone. And then when I was president, all the time, whenever we had discussion about organizing some academic program for some books, for some classes, for some hands-on training on this, IPCA was always on the forefront to participate into that. So I must thank IPCA special thanks for doing so much of a thing for urology trainees. And that is how this Eurovidya 5 is in position. So both of you have joined. So this is the image. So what sort of an image it is? Dr. Ashay, can you answer?
Yes, sir. Sir, this is an
So
ultrasound
just
film of
describe.
the
This is
bladder.
the ultrasound plate which is being kept, and just describe. And you're asked to describe this ultrasound plate.
So there is a solitary irregular polypoidal
Yeah, go ahead.
ecogenic sort mostly posterior.
Okay. What else? See, one thing in exam, whenever you're asked in the exam
And
to describe anything, you have to just keep on describing. You don't have to stop, because if you stop, then the examiner will keep on asking questions. This is my tip to you. So you have to keep on describing. Now you have rightly said that this is a polypoidal mass. You can approximately say what size it could be. Nobody can say for sure what is the size, but you have to describe the characteristics of this mass. Whether you are seeing multiple masses or single mass, so you said it is a single mass. It is probably arising from the posterior wall. It is okay. The most important thing which you have to say is that whether it is a broad base, whether it is pedunculated, whether it is there are multiple fonts. So that is what is important thing to describe. Okay. Then rest of the bladder. In this plate, what is the rest of the bladder showing? It is partially full, and there are no ecogenic material, there are no clots, there is no stone. So these important negative findings you keep on telling. Don't just stop. Everything is normal doesn't mean that you just stop. So, and what else you have to see in the given plate? If it is not seen, you have to tell that it is not seen. What is it? So in a given plate, you also have to see if there is any dilated ureter seen just behind the mass or not. If it is seen, it is all right. If it is not seen, then you say that okay, there is a mass, there is no ureteric dilatations, or there is no other thing seen. The bladder is partially distended. There are no clots, there is no stone, there is no ecogenic material in the bladder. So in a given plate, what is your impression? So what do you think it is?
sir, my impression is this will be intravesical soft tissue mass arising from the
Yes. Yes. Oh, your voice is
bladder.
a little bit. Okay, Dr. Kalicharan, what
Approximately
is your diagnosis? How will you, what is your diagnosis in this?
That is most likely a soft tissue tumor arising, soft tissue bladder mass arising from the posterior wall of the bladder.
Yeah.
Without involving, because there is no ureteral necrosis. I think it is not involving the VUJ.
Yeah.
And mostly it is malignant.
So what you have to tell, see, all these things, there are unnecessary things are not required because they will not give you marks. You say that there is a single polypoidal projection from the posterior bladder wall, and it has got a little broad base, and it is very likely that in a 65 years old hematuria, it is very likely to be carcinoma of the bladder. But that's it. Okay. So the next question, moment you say this, okay, what next you want to do?
So
see, this is how the Viva will proceed. Like that.
I would like to get an RFT, renal function test and CCT urogram, sir, to work up the urinary blood.
Okay, so why you want to do, suppose renal function is normal, you want to do CT IVP.
Yes.
Why you want to do that?
So to evaluate the entire.
So in short, you tell me what are the indications of the upper tract CT or do CT IVP in a suspected case of CA bladder. In every case you will do it, or in selected cases you will do it, or blanket moment you see any tumor in the bladder, you have to do a CT IVP if creatinine is normal. Is that the guideline?
So to see the extent of the tumor, to see any other masses are there, to evaluate the ureter for any other.
No, ultrasound of course will show you that there is no hydronephrosis, there is no dilatation. The moment you are shown ultrasound, important thing is that you have to ask for the other findings. Other findings is that there is no hydronephrosis, there is no the renal function is normal, no dilatation of the ureter, there is nothing, and you just had one episode of hematuria, painless hematuria. So now the question is that whether you will ask for blanket CT IVP in all the cases, or there are selected indications for CT IVP. What does guidelines say?
Not in all cases, few selected cases.
So what are those selected cases?
Broad-based tumor mass.
Okay, broad-based mass. Then
multiple masses.
Okay, multiple broad-based, and then
gross hematuria. And
gross hematuria is not a thing. Hematuria is hematuria. Yes, Dr. Patil, you want to add something? So multiple masses, even if it is a single mass, if it is a large mass, is definitely indication of doing CT IVP. Only in a case where there is a solitary less than 2 centimeter growth, you can avoid CT IVP. Otherwise, in most cases, it is required. Understand? Okay. So CT IVP you want to do? All right. So now I will show you the plate. Upper tracts are normal, and this is what is the cystogram plate. Anything else you want to know from CT scan?
Sir, about any pelvic lymph nodes or
no lymph nodes.
any metastasis?
No, on the CT abdomen, no metastasis, no pelvic lymph nodes, upper tracts, no filling defect, normal excretion both sides, no dilatation of the ureter, nothing. And this is a cystogram plate.
Surrounding planes of the bladder walls.
What do you mean by that?
It's local extension.
So how can you see that in CT IVP?
For perivesical soft.
So how do you see that? Perivesical what?
Perivesical soft tissue extension of the tumor.
Yeah, so that is the local staging. So CT IVP, you have to see the local staging. That is absolutely normal. There's nothing, no extension outside the bladder. So what next you want to do?
Sir, I would like to go for diagnostic cystoscopy and TRBT.
Okay, you don't want to do cytology? Is it necessary? What is the role of cytology in a given case like this?
Sessile broad-based tumors and high-grade tumors likely will have positive.
No, I'm asking you a simple question. Will you do cytology, or you think it is absolutely not required? I'll straight away go ahead with cystoscopy and TRBT.
I'll go ahead with cytology.
You want to go with cytology? Why? Is it going to change your diagnosis? Is it going to change your approach? Is it going to change your treatment option?
No.
Then why you want to do it?
high grade tumors likely will have given cytology for cystoscopy.
So that we don't know. No, you have not done this. You have not done T resection at all. I'm just asking you after seeing this whether you want to do cytology or not, and your answer should be straightforward.
The cystoscopy is gold standard, but if we get a negative cystoscopy, then I would like to go for a cytology.
How can cystoscopy be negative? You have this mass here very clearly. So how can there be a negative cystoscopy? That is all right in the follow-up. In a follow-up, when you're doing, that is one of the indication of cytology. I'm asking this case, straightforward case.
No rule, sir.
Okay, no role. That is wrong. The cytology has a role to play. What is the logic of cytology? Okay, now you know that this is a pedunculated mass. Okay, now when you do cytology beforehand, suppose you resect it and the report comes as low grade TA, and you have done cytology before and cytology was positive, and the resection part is low grade TA. What is the meaning of this? What is the meaning of this? Is it acceptable or it is not acceptable, or you have to think of something else?
Not acceptable. We have to look for CIN.
Yes.
Yeah, so the logic of cytology is that if it is positive, it has a lot of significance. If it is negative, it has no relevance. If it is positive, it suggests that there is a high grade tumor somewhere. Low grade tumor, very, very unlikely that cytology will be positive. And therefore, the classic description or classic reason is that such small tumor, pedunculated solitary tumor mass, it could be TA, low grade TA. But if cytology is positive, then you necessarily have to see whether there is any CA in situ or not, or whether there is any upper tract malignancy or not. Sometimes CTIVP is not that sensitive. So you have to aggressively suspect that there is a problem. Understand? If it is, if cytology is negative and it becomes high grade, it is okay. I mean, sometimes it is negative. It is not 100% foolproof. If it is positive and you get high grade T1 disease, it is okay. It is still acceptable. But whenever cytology is positive, you have to be very, very careful. Understand?
Yes.
So that is the reason. All right. So you do cystoscopy and TURBT. What else you want to see in cystoscopy TURBT?
Involvement of muscular propria.
No, that you will resect it out. That is histology. That is histology. But on cystoscopy, what else you want to see?
Distance of mass from trigone and orifices.
Okay. Location. What else? What else? Okay, let's move forward. On cystoscopy, you have to first confirm whether it is a solitary tumor or there are multiple tumors, because sonography and CTIVP can miss some small tumor. Cystoscopy, you also have to see if there are any red patches or not, which suggests that CA in situ, which may not be picked up on the CTIVP. You necessarily, if there is a facility available, you have to do narrowband imaging to see if there is any suspicious of CA in situ or not. You also have to see the distance of the ureteric orifice from the tumor, distance of tumor from the bladder neck. Why all this is important? What is the relevance of all this?
Sir, for planning the TURBT.
Yeah. So if it is near the ureteric orifice, then your resection has to be carefully planned, because you should not be damaging the ureteric orifice if it is near the ureteric orifice. Similarly, if the tumor is very near the bladder neck, then you also have to see whether it is extending and going into the prostatic urethra or not, because the whole thing, the whole management concept will completely change if it is prostatic urethra is going into the prostatic urethra or not. Okay, so this is what we have to answer. Let us go forward with the next case, and Dr. Tiwari also will ask the question. Kalicharan, you can take this. This is a 35 years old male who had fractured pelvis, ruptured urethra 3 months back. He was just put on suprapubic cystostomy at that time. The X-ray showed undisplaced upper and inferior pubic rami fracture on both sides. And at 3 months, this is RGO and MCU.
So the first one is retrograde urethra cancer.
Yeah, so this is sorry, first one is RGO. This is wrongly labeled. This is RGO, and this is the MCU. Okay.
Retrograde urethra, it is properly exposed, properly positioned film of retrograde urethra cancer. It's smooth. With smooth outline of anterior urethra and abrupt cutoff at the level of bulbar urethra. Most likely pelvic fracture urethral injury.
And what is the diagnosis?
So pelvic fracture urethral injury.
Pelvic fracture urethral injury. What about MCU? You have not described MCU.
So MCUG shows uniformly opacified bladder with opening bladder neck is adequately open, sir.
Where it is open?
No, not open.
Where, can you see the bladder neck? Where is the bladder neck? There is nothing bladder neck.
No, bladder neck is not open.
So what is the meaning of bladder neck is not open? Is it a bladder neck injury or what? Yes, Dr. Patil.
Sir, this RGO and MCU demonstrate a posterior urethral distraction injury, approximately.
Is
importance of bladder neck opening or not opening?
Yeah, that is what is the question.
Bladder neck has not opened. What are the reasons? Can you open the bladder neck by some maneuvers?
Yeah.
So by straining or by giving serotonin before alpha blockers.
So by giving alpha blockers 3 to 4 hours before, yes, bladder neck can open. So if the bladder has not opened, what does it signify? That at least bladder neck is competent. Okay. Because why it is important to know about bladder neck in such type of injuries?
To assess the outcome of definitive surgery.
How?
No, not outcome. It is the planning of the surgery. If bladder neck is opened and it is patent, there is a completely different outlook altogether. And if you see the bladder neck is injured and there is a transection of bladder neck, then it's a completely different planning. It is not the outcome. It is the planning. So in most of the cases, what it is it double injury or it is the bladder neck which does not open up because of what? Okay, let's not waste time.
Yes, because of the spasm, bladder may not open.
Yeah, so it is quite often this is a situation where bladder neck does not get opened up because of the spasm. Understand? So how will you assess the prostatic urethra? Now you have done MCU, you are told to strain, but still it is not opening up. So what next you want to do? You have to confirm that prostatic urethra is okay, isn't it? By? Okay, so you want to do suprapubic cystoscopy to see the bladder neck and to see the prostatic urethra. Okay, suppose there is a prostatic urethra is all right, and this is the classic bulbomembranous disruption, PFUDD. So what will you do?
What else will you like to know from the history in such type of injuries? Apart from urethral injury, what other injuries may happen, may be associated with such type of trauma, and which is important in planning the injury and knowing the result of injuries of your operation.
Pelvic injuries, we need to.
So you have to ask about the erectile dysfunction, and because they may be associated. That is important now. To ask about the erectile dysfunction. Why? Why it is important?
Because pelvic fracture can cause neurovascular injury, which causes erectile dysfunction.
So vascular injuries and neurogenic injuries both can cause. So if there is a vascular injury, that can influence the result of your operation. So you must know, and for medical legal purposes, it's also important to ask about the erectile functions.
Correct.
So how will you proceed further?
So what is operation? Simple. One single answer. Operation. What operation is done? Fracture pelvis, rupture urethra, complete disruption.
Anastomotic.
So you have to tell that it's an end-to-end urethroplasty.
Yes.
All right. So let's go to the next X-ray. This is an antenatal detection of unilateral hydronephrosis, and this is the ultrasonography done after 2 days of birth. The other kidney is normal. This is one side picture. So read this ultrasound and tell what next you want to do. Child is perfectly okay, full-term delivery, normal birth weight, crying normally, passing urine well, everything is fine. And 2 days after birth, this is the X-ray. Sorry, this is the sonography. Chalo, quick.
This is a postnatal ultrasound showing hydronephrosis of the right.
Yes.
So
So
right kidney.
what next? Other kidney is normal. Child is all right, creatine, everything, whatever you want to do it is all normal. Passing urine well. Male child, good flow, nothing, no problem.
So, sir, can I know about the ureter if it is dilated or not?
No dilatation of the ureter. On sonography, it's only
Only kidney.
pelvis hydronephrosis, no hydroureter. Bladder is normal.
So most likely diagnosis will be PUJ obstruction.
So what will you do next? They are anxious. It's 2 days old child.
So then I would like to do a MAC3 scan to assess for function and range.
Okay. When?
Um,
Dr. Kalcharan, you agree with him? Next step is MAC3.
So follow up after 1 month with ultrasound in the APT diameter.
Follow up after 1 month. Okay. So after 1 month, the picture is same. Child is asymptomatic.
So if the APT diameter is not increasing and the parenchyma is.
You see the parenchyma, what it is. The same.
but then at 1 month, I would like to do a MAC3 scan and manage according to that report.
So why not at 2 days? In short, when you get the antenatal detection of hydronephrosis, which is confirmed postnatally unilateral, what are the steps you take? So it's a very clear-cut algorithm. What steps to be taken? What is to be done at what time interval? What is the justification? Why it is not to be done? Why it is to be done? So there's all justification for this. All right. So let me just tell you, because we don't have much time. This is a unilateral hydronephrosis, very likely to be PUJ obstruction. Now you always have to see this is a very significant gross hydronephrosis. So it is not only the pelvis which is dilated, but there is the calyces are dilated, and the parenchyma also is quite thinned out. So there's a significant PUJ obstruction. In a unilateral case, there is no hurry. Why you don't want to do any isotope rhinogram, whether it is MAC3, whether it is TTPA, whatever EC scan, whatever you want to do, because kidneys are still immature and your functional assessment is not going to be perfect. So there is no logic of doing the isotope study immediately after birth. It will give a wrong result. It will be either falsely positive, falsely negative. Understand? So kidney maturity takes place, continues to happen even after birth. And therefore, if it is a bilateral hydronephrosis, the earliest scan you can do is at 6 weeks. If it is unilateral, you can do it at 3 months. Understand? Now people have started reducing the time, but the justification for not doing anything is that if there is an obstruction, by just waiting for 2 months, nothing is going to happen to kidney. It is not that suddenly the kidney will become non-functioning. If it was functioning at the time of birth, by waiting for 1 month, it will become non-functioning. It is very, very unlikely. It is not the pathophysiology of PUJ obstruction. It's a partial obstruction. It takes long time. If it is a gross hydronephrosis and poorly functioning kidney, by birth defect itself, the kidney is poorly functioning. Understand? By waiting for 1 month or 6 weeks or 2 months, nothing is going to happen. Understand? So previously, the clear-cut concept was at 3 months. Now people have started reducing the time simply because previously the risk of you doing surgery for this was very high, anesthesia and other problem. Now it has become more or less quite standard. So people are doing it early, but certainly not at the birth. Understand? So the next step is the isotope study to find out if there is any, to find out the obstruction is obvious there, but how much is the function? Most important thing is the measurement of the AP diameter. If AP diameter is more than 20 millimeters at immediately after birth, very, very likely that this patient eventually will need some sort of an intervention. Understand?
Yes.
If AP diameter is less, it is possible that this may resolve. Understand? So that is the relevance of this. So this is the next X-ray. Dr. Patil, you can take this. Again, I'll just give you background. This patient is a 1-year-old child, male child, and he has difficulty in passing urine, interrupted flow, episodes of UTI since birth. No intervention has been done. So what is the likelihood?
This is a micturating cystourethrogram in which the bladder is distended
Yes.
with a smooth wall, and the bladder neck is dilated during birthing, and there is a dilatation of the posterior urethra with abrupt narrowing.
Okay. So what is your diagnosis?
Level of membranous urethra, which will be which is suggestive of posterior urethral valve.
Okay. So what next you want to do?
Sir, I would like to get the abdomen films also to see if there is VUR.
Very good. Okay. So this
And then,
picture is not a proper picture. So when you do MCO in a suspected case of PU valves, what are the plates you take?
Sir, plain scout films.
Plain scout film? Yes.
And then the
filling phase, pre-wide, and voiding phase.
Filling phase. Okay. Then voiding phase. Then
Post-wide.
post wide. You take AP view, oblique view. Which view?
AP views.
AP view. Okay. So how do you check in AP view about the urethra?
Oblique. Oblique.
So now you say oblique. Why you want to oblique view? What is the logic? Urethra is in the AP view only. It is only bulbar urethra which is seen in and opened up in oblique view. You are not interested in bulbar urethra. So why you want to have oblique plate?
So posterior urethra will be able to see in oblique plate.
So posterior urethra you can see in AP view also. Only thing is that bulbar urethra is end on in AP view, so you can't really comment upon the bulbar urethra. But prostatic urethra doesn't change in oblique or this. It is fixed urethra. So still, why you want to take oblique plate? What are the reasons of taking oblique plate? Okay, oblique plate is because you also have to see the abrupt cutoff from the at the bulbar
Post-abdominal
junction where there is a posterior valve just at the verumontanum. And the most important thing is that in the bladder also, if there is any diverticulum, significant diverticulum, or there are outpouching, they will not be seen on AP view unless and until you take oblique or lateral view. Understand? And what you said is right, that you have to take the full plate to see if there is any reflux or not. Okay. So okay, so this child is 1 year old, and this is what is diagnosed. So what next you want to do?
So first of all, I would like to stabilize this patient and drain his bladder and correct the metabolic abnormalities. Then after that, we can go for definitive valve ablation.
No, there is no metabolic abnormality. Child's creatinine is normal, and UTI was there in the past. So what is there to stabilize? He's stable.
Okay.
Bilateral hydronephrosis, but creatinine is normal. 0.2,
then-
0.3.
Then I would like to proceed with endoscopic valve ablation,
Okay.
either using cold knife or Bugbee electrode.
You want to use cold knife or Bugbee? How do you use cold knife for valve ablation?
Bugbee or hook.
Which hook?
Sir, we we will take an incision at 5, 7, and 12 o'clock, or 5, 5, and 7 o'clock.
With what? Cold knife?
Okay.
You said cold knife.
How you told ablation? How will you ablate by cold knife?
An incision by cold knife and ablation by cautery.
So incision you want to take at 5 and 7 with cold knife. How you will do that?
You will have to use some energy, na, to ablate the valve.
So how do you use cold knife? Cold knife is there any cold knife for valve ablation? What you said hook? Hook is
Hook electrode.
electrode. It's a cautery.
Electrode cautery.
It's a cautery. Or if hook is not there, use Bugbee.
Hmm.
Can you use laser?
Yes, sir, we can use laser.
Which is better? You have everything available. You have laser, you have holmium, you have TFL, you have Bugbee, you have hook, you have everything. What will you prefer? 1 year old child, male child. What will you prefer?
Laser is better.
Laser is best because it is costly. Is that the reason? Which laser? High power holmium, TFL, low power holmium. Which one?
Holmium.
Holmium, high power. Don't say that whatever is the costliest is best. It is wrong. It is not. What is the idea of fulguration of valve? See, you have to know if you say all these things, laser, and then you have to know the setting which have to be used in the urethra, that too in a 1 year old child. What are the settings that you will use? What is the chances of current dissipating? What are the disadvantages of laser? What are the benefits of cautery? These are all questions which will come up. Understand? So the simple answer is that preferable is the Bugbee electrode in a very small child. It can go in a neonatal cystoscope also. If the child is a little older, you can use the hook electrode with the resectoscope, pediatric resectoscope. With that, there is a precision in fulguration because you can engage with the hook, and with the cautery, just have to touch it, and then it will fulgurate the valve. Now lasers also have been used, but the setting has to be such that it is extremely low joules and very low frequency. Because the moment you use high frequency, the current, the laser energy will dissipate, and it will cause damage to the urethral mucosa. You don't want that to happen. Understand? Otherwise, child will end up with urethral stricture. Okay, Dr. Tiwari, you want to ask anything?
In cautery, we will use cutting or coagulating current. You should use cutting current.
Cutting.
Yeah, so use pure cut, no coagulation, because you want a precision cutting. So it's a pure cut which you use. Okay. Suppose the patient's creatinine was a little high, say creatinine of 1, bilateral hydronephrosis. Otherwise, child is all right, but the creatinine is 1, both sides hydronephrosis, and this is what you diagnose. What will you do? There's no reflux, no UTI.
Sir, for this upper tract deterioration, we can do a vesicostomy.
So straight away you will go for vasostomy, not pure fulguration. Is it?
Fulguration.
So when will you consider vasostomy? In all cases, if creatinine is high, is that correct?
So we can try keeping the patient on a catheter, but if in spite of catheter his upper tract is getting deteriorated, then we may consider
Straight away vasostomy is not the answer. You have to decompress. It is a high pressure bladder. So very much possible that if you put a catheter for some time, maybe 4 days, 5 days, 6 days, the hydronephrosis may come down and the creatinine may improve, and then you can do primary fulguration. Understand? Vasostomy has lots of problems. There are benefits and there are problems. Understand?
Yes, sir.
Okay, so let's go to we don't have much time, but okay, just quickly, just to last X-ray.
Mutating cystourethrogram, sir. Showing right grade 5 UR and left.
So read this X-ray. See in exam, suppose this is the X-ray which is kept. The examiner, how the questions will start. Read this X-ray, then you have to read it, and then examiner is going to listen to you whether you are missing any point or not, or whether you are telling all the points or not. So you tell all the points which you want to tell.
This is a micturating cystourethrogram, which is showing a adequately distended, smooth surface bladder with urethra appears normal, and this shows right-sided VUR, which is right side grade 4 and left side grade 3. And yes, sir.
Yes. What else?
Urethra appears normal.
Okay.
Showing AP and oblique views.
Yeah. So Dr. Kalicharan, what points he has missed? He has missed many points in describing this X-ray. Yes, we don't have much time. First of all, you said that it is well distended. It is not well distended. It is over distended. This is not the correct way of doing MCO. You see, the bladder has gone beyond the pelvic beam. It is reaching L4, L5 vertebra. Do you distend the bladder that much in a child? Never. That's the wrong thing. Understand? So this finding you should have told. It gives impression. See, in exam, when there are so many candidates appearing, there is always comparison. If you notice this point, the examiner will immediately, oh, yeah, this is the correct thing. He has told it properly. So it creates impression. In exam, it is always important to create impression. Okay, what is you have missed it? Urethra is all right. It is perfect. But what is this?
Balloon.
This is ballooning of prepuce. There's a contrast accumulation under the prepucial skin. So there is a phimosis. Understand? In a reflux, when you are suspecting a primary reflux, this finding is very, very important. If you had told this point that there is an over-distended bladder, the urethra is normal, there is no dilatation of the prostatic urethra, but there seems to be the contrast accumulation into the prepucial skin, very likely there is a phimosis. Could be physiological phimosis. But this gives extra points. You say, yes, candidate is properly seen everything. And then the other important thing which you should have told or it was expected out of you is that at the end you should tell that sir, post-white film is missing. Understand? So these are very, very important things. Now, this finding what you have described is everybody's going to describe. Grade 3, grade 4, there's nothing great. First year student also will tell. Urethra normal this. But these extra points, which are important, if you tell them, you will get extra marks. You will get clear impression. Okay. All right. So I think, Dr. Tiwari, can we stop and then go for the case?
Yes, sir. Yes.
Okay. So I will stop sharing and I will start sharing the. All right. Okay. So this is the history. 12-year-old boy, complaints of right flank pain off and on for last 1 year. Okay, now Dr. Patil, you take the lead and you ask whatever you want to ask. This is the only complaint which parents have brought this child.
So, I have to elaborate on the history?
Yeah.
Okay. Then
Like a case discussion. We have 45 minutes for case discussion.
then I would like to ask him the exact site and if the pain is radiating to the groin, if the pain is colicky or if the pain
Now,
is dilating.
12-year-old boy, you cannot ask all these things. You have to understand this is a 12-year-old boy who is not going to tell whether it is colicky and this is radiating or migrating and this that. It is okay in adult. You can ask them, pinpoint them with this that. This child is going to cry. The moment he sees you, he's going to cry. So you can't even ask. Understand? So in the pediatric patient, history taking has a little different aspect. You cannot ask the nature of the pain, whether it is throbbing, whether it is dilating. Child is child. You cannot tell a child that okay, you tell properly. Okay, what things you want to know? I can understand that you want to know the nature of the pain, but in a pediatric age group, there are a lot of things which have limitations in the history. First of all, majority of the history you have to take from parents. Child, 12-year boy can ask, can tell a few things, but especially if the child was 2 years, 3 years, he won't even talk to you. The moment he sees you, he's going to cry. So the parents, you have to ask the history. So 12-year boy, okay, quite often they are cooperative. They can tell. But what is more important?
Associated fever.
Okay.
To ask in the history, what are the cardinal points you should ask in any urological case? He has come with pain, so you should have asked for fever, you should have asked for hematuria, you should have asked for lower tract symptoms. So you should ask all those things. These are the questions to be asked in every urological patient. Lower tract as well as upper tract. If he has come with the upper tract problems, symptoms, you have to ask about the lower tracts. If he has come with the lower tract symptoms, you will have to ask about the upper tract symptoms. So you have to ask all those things.
Okay, so you ask for lower tract, whether there is any poor flow, difficulty in passing urine, frequency, how frequently it goes, whether he cries while passing urine, whether there is any blood in the urine, whether there is any pus in the urine, whether he gets repeated episodes of fever or not. So all these things are important. Understand? What else you want to ask? Okay, so this is the history. Okay, anything more you want to ask now? No fever, no hematuria, no lower tract, nothing.
Is your open surgery on the same side?
Yeah, same side, right side.
Any stone analysis? Sir?
So you want to know stone analysis? Okay.
Operative notes.
Operative notes are not there. They're washed out. पूरा बह गया, बारिश में चला गया. See, remember, this is where the students fumble, and it is very, very important for students to ask whenever there is open surgery. First of all, not what is the history given to you that some open surgery on the same side 5 years back. Now, operative notes, absolutely wrong answer. Because why will you ask for operative notes? Most of the times it is not there in exam. Nobody is going to carry the operative notes. But you have to ask parents as to what are the things. Whenever there is a history of previous surgery, stone surgery, you have to ask that what was the problem at that time, why was surgery done, whether it was emergency surgery or it was planned surgery, whether it was in severe agony, high grade fever. So you know for what sort of surgery it was done, whether it was planned or whether it was emergency, how long he was admitted. Understand whether he was admitted for 5 days or he was admitted for 1 month. You know there was a problem. If the parents say that no, actually he was admitted for a long time, there was a problem. That means there was a problem. Whether tubes were kept or not, the drainage you have to ask, nephrostomy you have to ask, how long the tubes were kept, whether there was wound was properly healed or not, whether resuturing was done or not, how long catheter was kept. All these things does not require a note. The parents will tell. Parents will know everything. They will tell properly that no child was admitted for such and such thing. There was high grade fever. Was they admitted? Then they gave saline. Then there was surgery done. After surgery, fever went down. They showed some stone. You can't say that as stone analysis. What sort of a stone was shown to them? How many stones were there? Many times the doctor will tell. So there is one big stone, or there was many stones. Parents also will ask how many stones were there, whether stones were shown or not. They will quite often preserve the stone. Then you ask whether it was color was white, black, blue, or yellow. So all this information will give you the background why the surgery was done. Understand? Whether there was any complication. If they say no, there was a tube kept in which there was a lot of urine coming out and that they removed the tube after 2 weeks, 3 weeks. That means you know there is a problem. There was some urinoma. There must be some leak. Whether stent was passed or not, parents will know whether they was readmitted, whether stent was removed or not. All this will give you the idea what surgery was done, what was the problem, and this is how you come to know. So if you tell the examiner that this is what is the history which you have got, you already passed. The examiner will not ask you anything further because they know that you are very attentive. You know everything what you want to ask for. Understand? But if you ask for the stone analysis, they will say we also don't do stone analysis. What are you asking for parents? That what is the stone analysis? You expect that parents will tell it's a uric acid stone? It's not, obviously not. Understand? Okay, so this is the information which you have to get. All right. So on examination, what next? So there is no other significant history. There was no episodes of fever, nothing. All right. So on examination, what things you want to check? This is the background that some stone surgery was done. So what do you think the open surgery was for? Do you think that it was pyelolithotomy or parents said that he was admitted, it was elective planned surgery and there was no problem. There was no tube kept or anything, and the sutures were removed on the 8th day, and they were shown one single stone which was removed. And after that, child was all right. There was no stent, there was nothing, and the child was completely asymptomatic for so many years. And now for last some time he's having flank pain.
So
This might have been an open pyelolithotomy.
Open pyelolithotomy. Do you think that it was pyeloplasty with pyelolithotomy? One single small stone. Is it
Possible.
possible?
No.
How it is
Possible.
possible?
a single stone.
Was it a ureterolithotomy? Single stone.
Ureterolithotomy would be an emergency surgery, mostly.
So every ureteric stone is emergency?
No.
It is elective. It's a PUJ, upper ureteric stone, same flank pain. So you see, why I'm asking you all this thing, because it has got implication in your diagnosis, differential diagnosis. After the history taking, you have to tell what is your differential diagnosis. Or after examination, you have to tell what is the differential diagnosis. So all these things will come. When you present the case, your history is over, examination is over. The next question in any case, whichever case you are presenting, short case, long case, is what is your DD? So in DD, you have to tell that what is you can't just say only one diagnosis, that there is a stone. So all these things will suggest you that, okay, there can be secondary PUJ, there can be ureteric stricture, there can be PUJ obstruction, there can be recurrence of stone. There are so many things which are there. Understand? So in examination, what things you want to see? Anything specific?
The hypertension might be there.
There is no hypertension. What is
Scar, about the scar, if it is a flank scar or loin scar.
flank scar?
Then we can see if the affected kidney is palpable or enlarged or something.
No lump, no kidney palpable, non-tender, no tenderness, well-healed scar, no incisional hernia, genitals normal, no phimosis, nothing.
Now, what is the differential diagnosis? Based on history and
The first, based on history and examination, differential diagnosis will be first of all recurrent stone disease. Second will be PUJO secondary to fibrosis after the open surgery, and third will be recurrent PUJO if the first surgery was pyeloplasty.
Can it be primary PUJ? And they missed it.
Primary PUJ unoperated.
It is possible. Then they thought it is a stone and remove the stone, the PUJ was there. So anything is possible, isn't it?
Yes, sir.
All right. Okay. So how will you proceed?
Routine investigations and ultrasound abdomen, ultrasound babies.
Okay. Routine means
Blood work.
so hemoglobin is okay, creatinine is 0.4, urine is this routine microscopic, culture is sterile. Not
Second
one
case.
So what next?
So I would like to go for a CCT IVU.
CCT, IVU. Why not NCCT? In a child, what do you do? NCCT or CT IVP?
NCC, low dose NCCT in a child.
There is nothing like low dose NCCT. Okay, low dose NCCT. Okay, so would you prefer that in this case?
Sir, since it is a horseshoe kidney, for better anatomical delineation, I would prefer contrast.
This was not a horseshoe kidney, normal kidney. Then NCCT would have been adequate.
To look for drainage, it is better. To
Huh?
rule out PUJ or to look for drainage of the contents. CECT was better.
So you want to see for drainage and therefore you want CCT. So that means in all PUJ cases, you do CCT or you do drainage you see on the DTPA. What is it?
your practice, probably you are in the third year. You must have done seen so many cases. What is your practice? Answer. What you have seen.
Non-contrast CT and DTPA for PUJO.
For this
so
case,
for
we found
PUJ it is okay, but for this case with this background, will you apply same thing? Non-contrast CT, you will get the idea of stone, and then drainage, for drainage you do DTPA. Is that okay? Will you apply the same argument for this case? Okay, let's not waste time. See, what are the, although guidelines say that in pediatric, it is NCCT which is preferred, but that is not for every case. If it is a recurrent stone, if there is a previous surgery, you necessarily have to do CT IVP because you don't know what sort of a callousal deformity it is, whether there is any infundibular stenosis or not, whether there is any PUJ obstruction or not, whether there are some calluses which are not functioning or not. Understand? So it is not a, in a recurrent case where there is a recurrence of disease, or in a previously operated case, there is no shortcut for NCCT. It has to be CT IVP because CT IVP will give you idea about the anatomy as well as the physiology of the kidney. Ultrasound and DTPA, why it is combined? Because anatomy gives you, ultrasound gives you anatomy and DTPA gives you physiology. Okay, but CT IVP is one investigation where you get both. Understand? You get the function, at the same time you get the anatomy, proper planning. Especially in anomalous kidney, you can always justify doing CT-IVP because it's anomalous kidney. You want to see the drainage, you want to see how is the insertion of PUJ, how is the isthmus, how is the opposite kidney joining up, whether there is any contrast pulling in the isthmus or not. So all these things are required.
And also about the adjacent organs, where the college is retrorenal or
Correct.
like that.
So anyway, this is the CT-IVP. So this is what is the picture. Okay, so what will you do? On ultrasound, the stones were in lower calyx, so probably these are the stones here. So what next will you do now? This is what is the reconstructed plate, and these are all multiple plates. So what will you do? So tell how to manage the stone.
Sir, what is the comment on drainage in the CTIV report?
So draining well. Post-wide show, post-delayed plate show good drainage. Even this ureter is properly visualized. So good drainage.
And the stone location is in pelvis or lower colon?
Lower calyx. So this is the location of the, see corresponding this. This is where is the location. This is where is the location. So what will you do? So what is the diagnosis? Do you want in the workup or workup is over? Now you straight away go for treatment.
That one can be done.
What are the options you have? What are the options you have for the treatment?
Why you're
Since it is a horseshoe kidney, then open and laparoscopic stone retrieval.
open? So you do redo open surgery. So what are the problems of redo open surgery?
Fibrosis, additions, difficulty,
Lots of planes and
loss of planes.
So very difficult, no? You may not get into the plane. You may not, the kidney may be totally adherent. You may not be able to isolate. You may damage. Open surgery, redo open surgery is very hazardous. So why you want to do redo open surgery? Is there any endoscopic method? In a horseshoe kidney, how do you do laparoscopic thing? In a lower calyx, in a horseshoe kidney, the calyces are facing posteriorly.
posterior.
So when you go laparoscopically, how do you go into the posterior facing calyces? So
You can try descending followed by RRS.
descending followed by RRS. So what is the volume of this? 23.7 millimeter.
Staged
Lower-
RRS.
Stage
lower
RRS.
calyx.
So what is the role of PCNL in this case? In a horseshoe kidney. Now the whole discussion is going to be on a horseshoe kidney. If you have seen horseshoe kidney in your residency, whether it is child, whether it is pediatric, whether it is adult, that is male, that is female, horseshoe kidney, what are the management options of a stone in a horseshoe kidney? This is where the whole discussion is going to be, will proceed. So in a horseshoe kidney, what are the options? Is RRS an option in a horseshoe kidney? What are the hazards of RRS in a horseshoe kidney? Even if you put a pre-stenting and plan for 2-stage and this, what are the hazards? Especially if it is a lower calyceal stone. The PUJ goes on the isthmus. There is an acute overriding of the isthmus. So when you put a RRS, it has to go across over the isthmus and go into across the PUJ into the pelvis. The lower calyces are medially rotated. You see now, in a normal kidney, the lower calyx would have been here. Now the lower calyx is here. It is medial. Understand? There will be isthmus here. So this is upper calyx, middle calyx, so lower calyx. So lower calyces are facing medially and posteriorly. Understand? So in RRS, there will be acute angle, and you will never be able to reach. Many times you will not be able to reach into the lower calyx because it's an acute angle. You are overriding the isthmus, and then you want to bend it immediately, which many times in RRS is not possible. As against to that, what are the benefits of PCNL in a horseshoe kidney? Okay, enumerate benefits of PCNL in horseshoe kidney. Forget child, forget pediatric, forget any adult or whatever.
Sir, upper pole access is easier in horseshoe kidney because kidneys are lower and less chance of pleural injury.
Okay, so upper pole access is better. Kidney is low lying. Okay,
Low
that's one benefit. Okay,
And posterior calyx will be easy from for PCNL.
okay.
Posterior calyx.
So the calyces orientation is posterior, so you don't have to go lateral. You can go from the posterior side, and the upper calyx approach can be made because they are all facing posteriorly. Okay, what else are the benefits?
So larger stone load can be tackled with PCNL
Okay, what else?
in single setting.
Yeah, what else? What else? When you take the upper calyx approach, especially the posterior upper calyx approach, then you will straight away go into the pelvis. Because if you go from here, you are straight away going into the pelvis, and if you bend it, you are straight away into the lower calyx.
All calyces can be
All calyces except the middle one, where you have to bend it. You will be able to approach the PUJ stone, upper uretic stone, and the lower calyceal stones are very easily accessible by upper calyx approach. Understand? If you make the upper calyx approach and if there is a stone in the infundibulum, how do you approach it? So when you see from above, you will see the PUJ, just besides that is the lower calyx. You can straight away go in a straight line into the lower calyx. But from the lower calyx, there is a medial angle from where the isthmus will go. And many times this is the acute angle. You cannot go. So for stomach stone, you have to use the flexible nephroscope. So lower calyceal things can be tackled by the rigid nephroscopes. And if there is an extension or if there is a stone in the isthmus, it can be tackled by the flexible nephroscope. Understand? So that is what can be done. So the horseshoe kidney stone, PCNL is the first choice. Understand? Not the RIRS. whatever stage, whatever pre-stenting you do, because there are disadvantages of RIRS. As I said, it is the overriding the isthmus, acute angle, especially if it is lower calyx. If it is upper calyx stone, it is okay. You can still approach with a flexible, there is no problem. But if it is a isthmus stone and the inferior calyceal stone, very, very difficult to approach with the RIRS. Whereas it is easily accessible for PCNL because it is in a straight line. Okay, what else are the benefits and hazards of PCNL in a case like this 12-year-old child? Anything else you want to tell about the PCNL? What sort of energy source you will use? Is it a hard stone or a soft stone? Have you checked for the HU of the stone? Is it relevant?
Yes, sir. Sir, with rigid nephroscope, I would like to use pneumatic lithotripsy. Otherwise, for flexible nephroscope, laser, thulium fiber laser.
By pneumolithotripsy, you can take the stones and clear the fragments easily.
Yes, sir.
Very rapidly. It's not time. So now, will you like to put nephrostomy or you will just do tubeless?
Nephrostomy and degestent, and then remove the nephrostomy in the same admission.
When you call it tubeless and when you call it totally tubeless?
Tubeless is when we don't place a nephrostomy tube, only place degestent, and totally tubeless is when we don't place degestent also.
Okay. Okay. So here what do we do?
Sir, I will keep both.
We will keep both.
And keep the nephrostomy clamped for 6 hours, and next morning, if there is no fever, I will remove.
Can you hear me?
Yes,
Yes.
yes.
Okay, there was some problem of light, so I was temporarily cut off. Okay, all right. So continue, Dr. Tiwari.
So he will put both nephrostomy and we were discussing about tubeless and totally tubeless.
Okay, okay.
So he will like to put nephrostomy as well as stain.
degestent.
Yes.
Okay.
He clamp it for 6 hours and then he will remove it next day.
Yes, sir. Next morning.
Next one.
Okay.
So how do you?
Okay, so everything is done. Now patient is ready for discharge. So what advice you will give? The parents are worried the second time stone is formed. What to do? The 12-year-old child, twice stone intervention. So what is the problem?
So let's do analysis to rule out genetic conditions.
Hmm?
We
Stone
will
analysis.
Okay,
Stone analysis. Stone analysis is standard. Calcium oxalate, dihydrate, monohydrate, some sort of a uric acid component 5%. So standard printed report. What else?
I can counsel about hydration to increase the fluid intake so that urine is pale yellow.
Okay.
And then,
In
not to
metabolic workup,
metabolic work.
is it required?
Yes.
What metabolic workup?
So blood calcium, blood phosphate, serum calcium, serum phosphate, serum uric acid, then serum electrolyte, creatinine, and serum PTH, bicarbonate, and then in urine or normal urine analysis, urine culture, and then spot UPCR, and then 24-hour urine calcium, oxalate, citrate,
Urine
uric acid.
culture and all is not a metabolic workup. That is a different thing.
Urine, 24-hour urine for calcium, oxalate, citrate, uric acid, sodium, and cysteine.
Cysteine.
Is possible.
If possible means what? Everything is possible. Why you want to do cysteine?
If there is any family history, then
Family history, what family history? Cysteine stone is what? What sort of a stone is cysteine stone? Cysteine stone is radiopaque stone or it is radiolucent stone? So you think it is a cysteine stone?
No, sir.
Have you seen cysteine stone? Have you heard of cysteine stone?
It is faint on X-ray, less than
Faint on X-ray. Okay.
less than 500 HU.
Okay. So cysteine stones are not seen generally in India. Okay, they are very rare. They are common in outside abroad. So all this metabolic workup, what is the purpose of metabolic workup? You think there is abnormality of the metabolites? How does citrate 24 hours citrate is relevant? How is 24 hours magnesium is relevant? Of all the 24 hours, of all the 24 hours tests you have done, which is the most critical of formation of stones?
So it is important in pediatric population because they might have some kind of a metabolic abnormality, right? Hypercalciuria or hypocytraturia, hyperoxaluria.
So hypocytraturia is because of what? What abnormality you get because of hypocytraturia? What abnormality you get? Hypocytraturia and how you rectify it?
We can rectify it by potassium citrate.
Potassium citrate otherwise, and he's getting severe vomiting and diarrhea. Potassium citrate. So parents have come back, say you can't tolerate this medicine. How does citrate cause stones? Hypocytrate cause stone.
Because there will be more free calcium in the urine. That's why it will form normal calcium oxalate stones will be formed in hypocytraturia. Because it doesn't bind to calcium. The citrate normally binds to calcium, and if there is no citrate, then free calcium will be there, which will bind to oxalate and then form stone.
So citrate is causes inhibition. It is what inhibitory activity for formation of a stone. Understand? There is no abnormality, metabolic abnormality or genetic abnormality where it's not a hormone study or it's not a PTH or it is not something like that where genetically they are calcium losers or oxalates are high. So it has to be managed basically by the oral intake. So citrate fruits, citrate
Fruits and
this should
vegetables.
be so fruits and this should be done more in with citrate. Okay, so the any quantity which is more in citrate should be done with that. Okay, all right. How does magnesium help? Hypomagnesemia, how does it cause stone?
So magnesium is also an inhibitor
Okay,
In
so
the
magnesium
magnesium
also
also
has a similar activity that if there is any less level of magnesium, the formation it is inhibitory factor activity is inhibited, and therefore there are more chances of formation of stone. Any 24-hour study, the urinary oxalate is very very critical. Even with marginal increase in the urinary oxalate level, there will be higher chances of formation of a stone, much higher than hypercalciuria. Understand? So oxalate excretion has to be reduced under any circumstances. In a recurrent stone formation, oxalates are very critical. Oxalate levels, even if they are marginally high, that has to be appropriately treated. So how do you treat hyperoxaluria?
increase
Is
fluid intake.
excreting more. Yeah, that fluid intake is general. That is all right.
Reduce oxalate rich foods. Like
Reduce oxalate rich food. Okay. Then
calcium
what
by
else?
the fluid.
Calcium.
Calcium citrate.
Child is not obeying. Child wants to have chocolates. The child is addicted to chocolates. So what can be done?
Calcium supplements can
Calcium supplement.
citrate carbohydrates.
Oxalate will not absorb if you give calcium
Yeah.
through the diet.
So quite often the children, especially, you cannot restrict them to many things. If you restrict them, they will go in the school and then they will eat chocolate. So you can't do that. So how to counteract is that whenever you have high oxalate content, then you have to also give calcium along with it. So what happens is that oxalates, when you eat in the gut, the calcium, the simultaneous calcium will bind the oxalate, and calcium oxalate cannot be absorbed from the intestine. Understand? If the oxalates are in free form with any other salt, it will get absorbed and then it will go into the urine. But if the oxalates in the intestine they bind with the calcium, then the intestines have no capacity to absorb. It will all get excreted. And therefore, with the high oxalate content, you also necessarily have to give the simultaneous calcium intake, so that your oxalate intake is compensated by the so there's no increased chances of stone formation. Okay. All right. So how will you follow up this case?
Sir, no, I will give him a date for his digestion removal. 2 weeks for the PCNL stitch removal and 6 weeks for digestion
Oh,
removal.
that is all done. Stent and everything is removed. So now what next?
So I will advise him about hydration. And
So will you frequently call him for checkup?
6 months.
6 monthly checkup with what? Ultrasound, CT scan,
Ultrasound.
ultrasound. So apart from all the dietary restrictions and all the things, most of the times they will obey the dietary plan and everything for first 6 months. After that, they will forget it. So most important thing is frequent follow-up, because come what may, many times all metabolic study will be normal, and therefore the strict advice is that regular checkup. So in case if there is any small stones, they can be medically treated rather than requiring intervention. Right, Dr. Tiwari, you want to ask anything, because we are almost at the end of the session.
So they have to read and present more cases like that and attend more sessions like that to answer. Because
Correct.
and you have to put all the things in a systematic manner, in a precise manner, and your answers should be correct and appropriate, and swiftly you have to answer. You are not like for waste your time and examiner's time. Then they will ask by irritating examiners ask difficult questions. So you have to answer and whatever is asked, you have to answer immediately. Suppose in imaging, you have to identify the image, what image it is, what are the positive findings, and then give the chances to the examiner to ask about the differential diagnosis of that positive finding, what it is on the image. So repeated practice, and listening to such sessions, attending such sessions will update your knowledge and make the exam easier for stress-free, to be stress-free.
Yeah. So I think this is the correct advice, the golden advice. You have to keep on practicing since you are in the third year of your program. You have to keep on presenting the cases as much as possible. Now, USI does a lot of activities for students. They arrange the classes. There are mock exams. There is a recently mock exam coming up just I think in 1 or 2 weeks time. There are a lot of things which are happening at USI level, also at the zonal level. Almost each zone also does a lot of mock exams. So participate. In those programs, so you get exposure as to what questions can be asked. I think both of you answered quite well, but from exam point of view, you need something more preparation. Then see, knowledge is one thing, and appearing in exam is a different thing. There are people with the less knowledge do very well, and there are people who have excellent knowledge, but they don't do that much well in exam, because exam so it's a different ballgame altogether. So unless and until you attend these classes and attend such sessions at different levels, you will understand and you will be confident to appear for the exam. All right. So with this, I
yes,
think we will close down the session. And I once again thank Dr. Rajesh Tiwari for joining up, and IPCA team for making this possible. I'm sure the students will find it very interesting and beneficial. And back to Suruchi, I can see here, or Vishalji, if he's there. Back to you. Thank you very much.
Thank you, Sabni sir and Rajesh sir, for taking out the time and giving us such an informative session. I feel this interaction was more fruitful because looking at the discussion, the Viva is more critical part as during the examination, and must have addressed the queries of all the doctors whoever has logged in. Total today. There were around 150 plus logins onto the audience link. So I request one more thing, sir, Sabni sir, to request most of the residents to please come ahead and be the volunteers for all the sessions, because this interactive session is more fruitful in understanding and solving the queries in place of the monologue. So I would request more and more residents to come ahead and be the volunteers for the sessions lying ahead. So so tomorrow we have one more insightful session by Dr. Rohan Batra sir and Dr. Raman Talwar. It's on male infertility and physiology of penile erection. The time will remain the same from 7:30 onwards. Thank you, sir. Thank you.